Morning, dobre utro to everybody. I am in my office. I'm so sorry that I'm not there, and it is a real pity that we cannot stay together and take picture again together. It was a very hard year, but I'm so happy that I'm here today with you again. I am now in my office and in the room I used for the first consultation, and I will share this room with you, and I hope spend a couple of days which will be profitable for both, for me and for you. So this is just the beginning of these 2 hard days. Here is my laptop. Takes, I don't usually, a little bit of delay to come to you. We will be talking 2 days about early treatment, the rationale why we should do early treatment, the key points, the crucial points to be successful, and of course new procedures. First of all, I want to thank you, spasiba, all of you, for being here in the room with me today. It is a great pleasure. I don't know how many you are, and I miss your faces in front of me. But I know you are many, and so happy about it. So thank you very much for having done the trip to be in Moscow, to stay in a room without me, but you can enjoy, of course, your company. And thank you so much for being interested in my work. It is a great honor, a great privilege to me. I also have to say that it is a pleasure talking about early treatment with you, with my colleagues of the East of Europe, because I understood in the last year that you are really among the best in applying my concept to the daily work. So thank you, first of all, also for being interested in my work and for being in together to me today. Okay, let's start. We will talk 2 days about early treatment. Early treatment means growing patients. It is a pleasure to see these patients who grow up in our offices. We see not only the teeth changing, but the kids becoming adults, and this is a great privilege. Growing patient, and more specifically, I will talk about early treatment, the treatment we do in the primary or in the mixed dentition, that whatever we do before the ideal time for an orthodontic treatment, which is the beginning of the permanent dentition. Early treatment is all you do before having all the full permanent teeth. Of course, early treatment means the first stage of a 2-phase treatment. 2-phase treatment means that usually after the first stage in the mixed dentition, you have a second phase of treatment, what we call the finishing phase in permanent dentition. Today and tomorrow we will talk about the first phase, early treatment, what we do before the permanent dentition. But don't forget, we are talking about the 2-phase treatment. This means that usually early treatment has the mission not only to reduce the amplification of the malocclusion, not only to re-establish normal growth, but even more to reduce the invasivity of the second phase of treatment. Reduce the invasivity means a short second phase, the least time we can with appliances in contact to the permanent teeth. Appliances in contact to the permanent teeth during adolescence means something which is not safe for the teeth and for the adolescents. So we have to reduce the invasivity, the treatment time of the second phase of treatment. This is the real mission of the early treatment. The second phase quite often is necessary. To tell the truth, the second phase is always necessary if you really want to achieve the best. And more you will find patients who will ask you to get the best after an orthodontic treatment. So if you want to achieve what you see here, a beautiful alignment and a beautiful occlusion, a beautiful, let's say, perfection in the occlusion, in the aesthetic, you need a second phase always. And if you do a first phase of treatment and the second phase of treatment, treatment time will be longer. Will be longer means that sometimes, look at this patient, it takes 10 years, especially in the males, to see this patient growing up, changing the teeth, arriving at the end of the dentition and showing us the end of the treatment. And if treatment is longer and the result more or less is the same, many researchers think that in many malocclusion, a two-phase treatment could be maybe an over-treatment. Anna? Of course, I don't want to do an over-treatment to my patient, but I want to show you what I think is a better method in many malocclusion to achieve better results. This is the overall hypothesis I will discuss today. Sorry, I have a telephone call by Anna. Anna?
We can't see the slide.
You can?
Yes, we can see the slide. We can change the scenes, please. Comment 1. Comment. Just comment.
Are you seeing it now?
Just a second. No. Click comment.
Wait a moment, sorry. Now?
No. Will you connect to your computer now?
Yeah, everything is connected.
We need a password.
Can you see my screen? Anna?
Yeah, please accept our request. We connect to your computer.
Was not connected?
Yeah, now it's connected.
So now can you see the screen? Can I go?
No, just a second, I will tell you, and we can continue. Что? Open your slides on full screen.
Yeah.
And we can continue.
Can you see it?
Yeah, we can see it.
Do you see the two girls?
Yeah, perfect.
Okay, sorry. So thank you again for being here. And excuse me for this technical problem. I'm very sorry. So thank you very much. We will be talking about growing patient. Growing patient means the pleasure of seeing our kids in our office. I will talk about early treatment, which is the first phase of a two-phase treatment. Early treatment means whatever you do before the permanent dentition. When you are in permanent dentition and you apply a two-phase protocol, you need a second finishing phase when all the permanent teeth are out. And so today we will talk about whatever we do before the second phase of treatment. The real mission of the early treatment is not only to reduce the amplification of the malocclusion, not only to re-establish normal growth, but first of all to reduce the invasivity of the second phase of treatment. Second phase of treatment, appliance on permanent teeth, is often necessary, anyhow, is always necessary if you want to achieve what you see here, a beautiful result. If you want to achieve something which is perfect, you always need a second phase of treatment. This means that if we do one phase and the second phase of treatment, the observation time, treatment time, may be very long, 10 years in this case, to see the permanent teeth going up and to see his face developing at the best. And if treatment time is longer, and in many patients, the result is more or less the same. When we decide to do a two-phase treatment, the risk is that this long treatment may become an over-treatment, too much treatment. This is what many researchers, many orthodontists think. Of course, I don't want to do an over-treatment to my patient. I want to do whatever which can provide a better result, but even more, I want to teach you a better method to obtain maybe the same result, but in a better way. So we will be talking not only about the possibility of obtaining a better final outcome, but first of all, a better method, a better way to achieve perhaps same result, but in a better way, in a less invasive and biologic and physiologic way. Early treatment is, in my opinion, a better method, not only a better result in many malocclusion. Many malocclusion means that early treatment cannot be applied as a rule in all the malocclusion. Only in some malocclusion it is a better method. And this is the overall hypothesis I will discuss to you today. So, early treatment is a better method and becomes the better way to treat our sons, our patients, if we respect some key points. First of all, clear indication. Once again, early treatment cannot apply on a universal application on all the malocclusion. You must be able to select the patient. This means, first of all, you don't need the right appliance. You need the right diagnosis. This is fundamental. Otherwise, the risk of overtreatment will be very, very huge. Then, of course, we need a method. This is the topic of these 2 days. And we must become able to write on a paper before the beginning of treatment the goals we will achieve for sure during treatment. When you will be able to write and to do what you write during the early stage of treatment, it means that you are a good orthodontist, because you know what you want to do and you write it on a paper, and then for sure you will do it. So clear goals, but predictably achievable. These 4 points are the most important: case selection, diagnosis, a good method, simple method, effective method with a good cost-benefit ratio to achieve, for sure, goals which are well defined before treatment. So the method is our topic, not only the final result, but how to achieve them. I will be talking about an effective method. It works to treat in mixed dentition, not all, but some malocclusions. And I will tell you why, what is the reason why you should do it, and how to do it, the method, without touching permanent teeth. In 1998, I started this trip. So it is now a long time, 30 years that I'm working in the same time. And this is very important to underline, to let you know, because if I didn't change in 30 years, it means that it works. So in 1998, I was able to fix this crowding in the upper jaw in mixed dentition without touching permanent teeth, with no cooperation at all. In 1996, I was able to let the lower arch self-expand without touching permanent teeth, without cooperation. I want you to do the same. In 2000, I was able to correct in a predictable way, without touching permanent teeth and without cooperation, an anterior crossbite. A crowding plus an anterior crossbite was corrected in 1998 without touching permanent teeth, without cooperation. In these 30 years, I did a lot of improvements, and now everything is very clear and ready to be taught to you. I was able in 1994 to fix a posterior crossbite on the permanent teeth, on the permanent molars, without touching. Nothing, without touching permanent molars. To fix a class 2 without touching permanent molars. To fix a midline. And to correct much more difficult malocclusions. In this case, a class 2 crossbite malocclusion. I corrected the malocclusion and the permanent teeth without touching the teeth at all, and without cooperation. Without cooperation is a magic trick, is a magic tool, because it means that you can achieve it for sure. You don't have to ask work to the kids. Tomorrow we will talk also about skeletal problems, so class 3, how to correct a class 3 in an effective way in mixed dentition, and how to change the growth pattern the more we can in a predictable way. How to fix an open bite without touching permanent teeth, without functional appliances, without speech therapist, and in the meantime, how to recognize the patient who can grow in a beautiful way, without touching permanent teeth, without cooperation. There are 3 reasons why I advise you to learn how to treat the patient in mixed dentition without touching permanent teeth. Why should we work without touching permanent teeth? First of all, prevention, of course. When you use appliances bonded or in contact with the permanent teeth, you will augment the risk of having side effects, root resorption, enamel demineralization, periodontal damage. If we don't touch them, of course, we don't follow this risk. But the main reason why I want you to learn how to correct the malocclusion without touching permanent teeth is that this method works better. It is a better movement. You are doing something which is not only a better method, but will allow you to achieve a better result. If you become able to move the permanent molars without touching them, in this case, the permanent molars self-corrected spontaneously, the result is much better. you will be able, by means of this spontaneous movement of the permanent teeth, to get a more stable result. There is no relapse. When a crossbite fixes spontaneously, no relapse. And it will be easier to prevent one of the most popular, or the most common mistakes we do during orthodontic treatment, which is dental-alveolar compensation, which means put the teeth out of the periodontal envelope. We don't want to move the teeth out of the bone, out of the periodontal envelope. We want to keep them inside the periodontal envelope, which means no dental-alveolar compensation. If we are able to let the permanent incisors spontaneously derotate like this, believe me, the result is much more stable. This is 4 years after treatment without having touched the permanent incisors, no retention at all. So stability and no dental-alveolar compensation is our tool, our goal. And the third reason why we should work without touching permanent teeth is efficiency. Efficiency means a better cost-benefit ratio. Less cost, not only financial cost, but also biological cost, and a great benefit. Because permanent teeth self-correct. You don't have to spend time in sophisticated biomechanics. Patients are asked to give us just a little compliance, cooperation. Results becomes more predictable. Minimum working time of the chair means less cost, more time to do what you want. Everything goes itself, and you can treat more patients. The second phase becomes easier in many patients not looking for excellence, not necessary, and this means that the ratio, the cost-benefit ratio, is much better. So what is the keyword of this way of working? The keyword is mixed dentition. Mixed dentition means, don't forget, you have the milk teeth. In mixed dentition, we have 12 mixed milk teeth, deciduous teeth, primary teeth, and you have 12 permanent teeth. Well, what I want you to learn and to do every day is to work in the mixed dentition using the deciduous, the primary, the milk teeth, to drive the eruption of the permanent teeth and facial growth. We want to drive the growing patient to become more beautiful and to drive the teeth to erupt properly without touching them. But we need the milk teeth, we need the primary teeth, we need the deciduous teeth, especially the second upper molars and the canines. So the outline of these 2 days is this. I will be starting now in the next hour talking about crowding, then transverse discrepancies before lunch, then and this afternoon. Tomorrow we will talk about class 3, class 2, vertical discrepancies, and missing teeth in the mixed dentition. Today, crowding, transverse discrepancies. Tomorrow, skeletal problems and missing teeth. Crowding, let's start with crowding. Crowding means, in the mixed dentition, means that sometimes we have a beautiful primary dentition. The deciduous teeth, the milk teeth are so beautiful. Then around 6 years of age, during the first transitional period, it happens a disaster. The permanent incisors are much bigger and there is no space, so the parents worry. And the parents come to you and you immediately think, what is the best appliance to fix this crowding? But you are on a wrong direction. You don't have to think about the right appliance. First of all, you have to do a diagnosis. Diagnosis is the most important thing. Diagnosis means, of course, in front of a crowding, space analysis. A space analysis is done always starting in the lower arch. The space the first arch where to do a space analysis, the fundamental arch is the lower arch. So we do the space analysis in the lower arch, and depending how we will fix the crowding in the lower arch, we will decide what to do to fix the crowding. So in the lower arch, we see the permanent molars, the permanent incisors. The permanent incisor can be more protruded, less protruded, and of course, if you want to move the incisors lingually back, you need more space. So the protrusion of the lower incisors is very important to define the amount of space you need to fix the crowding. Of course, the protrusion of the lower incisor together with the position of the chin, of the mandibular symphysis, is what we call the profile, is also very important to decide how to fix the incisors and as a consequence, how to fix the crowding. The protrusion of the incisors means that you need more space to fix the crowding. Incisor protrusion profile means pattern of growth. Don't forget, we are not treating adults, we are treating growing patients. So what you see at the beginning of your therapeutical path is not what you see after growth. You have to be so able, and this is the most challenging part of our job, you must be able to do a growth prediction, because the protrusion of the incisor, the profile, will change a lot during growth. But if you are in the mixed dentition, there is something more you have to consider, which is the leeway space, 2-3 millimeters, which is the difference between the sum of the mesodistal diameters of the decidus canine and first, second premolar compared to the permanent canine and the two premolars. Usually the decidus teeth are a little bit wider and the space you get is 2-3 millimeter. We know that if we use this 2-3 millimeter of space, 70% of the lower crowding can be corrected without extraction. And then, of course, you have to consider the development of the dentition, because the kids are growing, not only the profile will change, but also the dental arches will change. And we know whatever we need to know since 1960. Silman, Maurice, Chada, they published in 1960 and 70 all the information we need. Nothing more, nothing new after that time. We learned that during the incisors eruption, the lateral incisor eruption, there is an increase in the perimeter of the arch during the incisors eruption. The intercanine width increases and the eruption of the incisor is a little bit more buccal. So we learned that the time where the arch length is maximum, where the arch length is the maximum, is the decidus dentition. We have diastemas, not only around the incisor, but also in the back segments. Then when you see the permanent molars erupting, they push forward. And the back diastema, the diastema on the back, closes itself. Then during the eruption of the lateral incisor, the intercanine width increases and the central incisors erupt a little bit more buccally. So you lose space behind and you gain space on the incisors. But the arch length more or less remain the same. This is the beautiful graph of Maurice and Chada, and you see M means molars. When the first molar, the permanent molars, erupt, you have a decrease in the perimeter of the arch, even more when erupt the second incisor, and then a little bit of growth, but the arch length was longer in deciduous dentition. So wait, before starting a treatment, wait the full eruption of the lateral incisors. Many patients shows an improvement, a spontaneous improvement during the eruption of the lateral incisor in the lower jaw. If this doesn't happen after the eruption of the lateral incisor, you can start treatment. The individual variation is very high, 2 to 6 millimeters, but some patients improved very much, only by growth. My take-home message is wait the eruption of the lateral incisor in the mandibular arch. This is a magic moment. Wait the eruption of the lower lateral incisor before start the treatment.